Blood supply of the heart. Arterial supply. Right coronary artery. The right coronary artery arises from the anterior aortic sinus of the ascending aorta. It ascends in the right atrioventricular groove and sends it descends in the right atrioventricular groove and sends branches to the right atrium and ventricle. It ends by anastomosing with the left coronary artery in the posterior interventricular groove. Branches. The right conus artery supplies the anterior surface of the infundibulum of the right ventricle and the upper part of the anterior wall of the right ventricle. The anterior ventricular branches are two or three in number and supply the anterior surface of the right ventricle. The marginal branch is the largest and it follows the lower margin of the cluster surface to reach the apex. The posterior ventricular branches are usually two in number and branches supply the diaphragmatic surface of the right ventricle. The posterior interventricular descending artery runs toward the apex in the posterior interventricular groove and sends branches to the right and the left ventricles. The atrial branches supply the anterior and the lateral surfaces of the right atrium. Left coronary artery. The left coronary artery arises from the left posterior aortic sinus of the ascending aorta. The left coronary artery is larger than the right coronary artery. In the atrioventricular groove, it divides into an anterior interventricular branch and a circumflex branch. Branches. The anterior interventricular descending branch runs downward in the anterior interventricular groove to the apex of the heart. In most individuals, it then passes around the apex of the heart, enters the posterior interventricular groove, and anastomoses with the terminal branches of the right coronary artery. In one third of individuals, it ends at the apex of the heart. This branch supplies the right and left ventricles. The circumflex artery is the same size as the anterior interventricular artery. It winds around the left margin of the heart in the atrioventricular groove. Left marginal, anterior ventricular, and posterior ventricular branches supply the left ventricle, and atrial branches supply the left atrium. The arrangement just described is subject to variation. In the case of right dominance, the posterior interventricular artery is a large branch of the right coronary artery. In case of left dominance, the posterior interventricular artery is a branch of left coronary artery. Coronary artery disease. Although the coronary arteries have numerous anastomoses at the arteriolar level, they are essentially functional end arteries. A sudden block of one of the large branches of either coronary artery will usually lead to necrosis of the cardiac muscle in the vascular area, and often the patient dies. Venous drainage. Most venous blood from the heart wall drains into the right atrium through the coronary sinus. The remainder drains directly into the right atrium through the anterior cardiac vein and small veins, the venae cordis minime. Coronary sinus. The coronary sinus lies in the posterior part of the atrioventricular groove. It is the largest vein draining the heart wall and is a continuation of the great cardiac vein. Great cardiac vein. The great cardiac vein ascends from the apex of the heart in the anterior interventricular groove. It then enters the atrioventricular groove, curves to the left side and back of the heart, and empties into the coronary sinus. Middle cardiac vein. The middle cardiac vein runs from the apex of the heart in the posterior interventricular groove and empties into the coronary sinus. Small cardiac vein. The small cardiac vein accompanies the marginal artery along the inferior border of the heart and empties into the coronary sinus. Anterior cardiac vein. The anterior cardiac vein drains the anterior surface of the right atrium and the right ventricle. It empties directly into the right atrium. Nerve supply of the heart. The heart is innervated by sympathetic and parasympathetic fibers of the autonomic nervous system via the cardiac plexuses. The postganglionic sympathetic fibers terminate on the sinoatrial and the atrioventricular nodes, cardiac muscle fibers, and coronary arteries. Activation of these nerves results in cardiac acceleration, increased force of contraction by the cardiac muscle, and dilatation of the coronary arteries. The parasympathetic fibers reach the cardiac plexuses in the vagus nerves. Postganglionic fibers terminate in the sinoatrial and the atrioventricular nodes and on the coronary arteries. Activation of the parasympathetic nerves results in a reduced rate and force of contraction by the heart and a constriction of the coronary arteries. Cardiac pain. Pain originating in the heart as the result of ischemia results in stimulation of the sensory nerve endings in the myocardium. The afferent nerve fibers ascend to the central nervous system via the sympathetic trunk and enter the spinal cord through the upper four thoracic nerves. The pain varies considerably from a severe crushing pain to nothing more than a mild discomfort. The pain is not felt in the heart but is referred to the skin area supplied by the corresponding spinal nerves. The skin areas supplied by the upper four intercostal nerves and by the intercostal brachial nerve T2 are therefore mainly affected. Gross anatomic changes in the fetal circulation at birth. When the umbilical cord is tied, the blood pressure in the inferior vena cava immediately falls. Coupled with the increased left atrial pressure from the increased pulmonary blood flow, this causes the foramen ovale to close. The diminished pulmonary vascular resistance associated with inflation of the lungs causes the direction of flow through the ductus arteriosus to change from right to left to the neonatal route of left to right. The ductus arteriosus constricts as a reaction of its muscle to the raised saturation, oxygen tension. It is it later closes and becomes the ligamentum arteriosum. In addition, the wall of the ductus venosus contracts and the ligament closes. Later, the ductus venosus becomes fibrosed to form the ligamentum venosum. Some important congenital cardiac defects. Some important congenital defects of the heart and great vessels. Atrial septal defect. In 25% of individuals, the foramen ovale does not completely close. When the opening is small, it has no clinical significance. Occasionally, however, the opening is large, and this results in oxygenated blood from the left atrium passing into the right atrium. Ventricular septal defects. The ventricular septum is normally formed by the fusion of the small membranous part with the larger lower muscular part. Ventricular septal defects occur in the membranous part of the septum. Oxygenated blood passes through the defect from left to right, causing enlargement of the right ventricle. Tetralogy or fallow. The following four defects occur with tetralogy of fallow. Large ventricular septal defect, stenosis of the pulmonary trunk, exit of the aorta from the heart immediately above the ventricular septal defect, hypertrophy of the right ventricle because of the resulting high blood pressure in that ventricle, patent ductus arteriosus. Normally, the ductus arteriosus has closed by the end of the first month after birth. Failure of the ductus arteriosus to close results in aortic blood passing into the pulmonary artery, which then raises the pressure in the pulmonary circulation and causes hypertrophy of the right ventricle. Coarctation of the aorta. Coarctation of the aorta is the narrowing of the aorta just proximal, opposite, or distal to the site of attachment of the ligamentum arteriosum. It arises after birth and is thought to result from the contraction of ductus arteriosus muscle tissue that has been incorporated in the wall of the aorta. When the ductus arteriosus contract normally, the aortic wall also contracts and the aortic lumen narrows. Later, fibrosis causes permanent narrowing. Large veins of the thorax. Brachiocephalic veins, superior vena cava, azygous vein, inferior hemiazygous vein, superior hemiazygous vein, and the inferior vena cava. Large veins of the thorax. Brachiocephalic veins. The right brachiocephalic vein is formed at the root of the neck by the union of the right subclavian and the right internal jugular veins. The left brachiocephalic vein has a similar origin on the left side of the root of the neck. It then passes downward and to the right, where it joins the right brachiocephalic vein to form the superior vena cava. Superior vena cava. The superior vena cava is a large vein formed by the union of the two brachiocephalic veins, and it descends vertically to drain into the right atrium of the heart. The azygous vein joins the posterior aspect of the superior vena cava. Azygous vein. The azygous vein has a variable origin, but it is commonly formed by the union of the right ascending lumbar vein and the right subcostal vein. It ascends through the aortic opening in the diaphragm and at the level of the fifth thoracic vertebra. It arches forward to join the superior vena cava. The azygous vein has numerous tributaries, including the 8 lower right intercostal veins, the right superior intercostal vein, the superior and inferior hemiazygous veins, and numerous mediastinal veins. Inferior hemiazygous vein. The inferior hemiazygous vein is formed by the union of the left ascending lumbar vein and the left subcostal vein. It ascends through the left crest of the diaphragm to join the azygous vein. Superior hemiazygous vein. The superior hemiazygous vein is formed by the union of the fourth with the 8th intercostal vein. It joins the azygous vein. Inferior vena cava. The inferior vena cava is formed in the abdomen. It perforates the central tendon of the diaphragm and the pericardium, and it then opens into the right atrium of the heart. Esophagus veins and cable obstruction. In obstruction of the superior or inferior vena